Well, good morning, everyone, and welcome to the Surviving Sepsis Campaign's session for this Congress. We're highlighting one of our initiatives over the last 2 or 3 years that we've been working on screening for patients with severe sepsis or septic shock on the wards and getting them to the appropriate level of care in a quick time frame. Different work than we've done in the past, where we focus mainly on the emergency departments in the ICU, and we like to showcase many of the pieces of that initiative today. I would like to thank first the Gordon and Betty Moore Foundation for sponsoring our work in the Surviving Sepsis Campaign. They have chiefly funded the efforts of the campaign since 2010, and this particular initiative was certainly funded by their work, and we're very grateful to them for their generosity in supporting the work of identifying and taking care of patients with severe sepsis and septic shock around the world. I'm happy to have been relegated to the role of moderator today because I feared the amount of tomatoes that might be thrown at me for SEP 1. I won't have much time on the stage, and these other gentlemen and ladies here will take up the space instead, which is all by design, I want to say. And so we should get started. I want to introduce first Christa Shore, who will speak on pitfalls and wins and staff buy-in for sepsis screening on the wards. Christa is Program Manager for Quality Improvement and Clinical Research Databases at Cooper University Hospital in Camden, New Jersey. She is presently completing her doctorate in nursing, and she's been a member of the Surviving Sepsis Campaign for 12 years, presently on the Executive Committee and the Guidelines Committee. Christa?
Thanks, Sean. It's my pleasure to present this topic to you. It's something that's very close to my heart, so hopefully you'll get that feeling as well. Basically, I'm going to talk about the nurse's perspective in this process, and when Mitchell presents the data, you'll see that it's really a nurse-driven process, sepsis screening on the wards. What we're going to strive for is here how to develop a good team, answer some questions as far as specifics to the collaborative on the wards, and how to establish good relationships. And primarily, the relationships are the physician and nurse relationship. So this is really what we're all striving for. This is our ICU team at our hospital, and you can see everyone's happy. It's a collaborative effort here where there's physicians, nurses, pharmacists, respiratory therapists, and this is really the collaborative work that we're striving for even outside the ICU. So what's holding us back? There are a lot of things. We work in silos. We're starting to realize now that sepsis is not just an ICU ED disease, that this is hospital-wide. And we need to think about this process in that fashion, that we need to work collaboratively. The communication process is different from unit to unit, and we need to recognize that there are differences. And we need to establish some sort of relationship that works from the ED all the way to the general medical floors. When we're thinking about actually developing a team, there are people that you actually want to start the program in your institution, and you need to think about the mindset of those folks. So there are a lot of people in your hospital that are very good at what they do, but everyone knows that there are some people that they view this as just a job, and we need those people to do tasks, obviously, but they may just come in, do their job, they do it very well, but they don't want to do anything else. And there are some people that are driven that this is their career. They come in, they do a great job, they start to volunteer for committees, and they're the type of people that you you want to include in these types of efforts. And then there are other people that they feel that this is their calling. This is something that they've been driven to do from the time they started as a nursing student. They said, I've always wanted to be a nurse. I remember when I was 5 years old, I decided that I wanted to be a nurse. So this is their passion. When you're trying to develop a team, those two combinations, those that are on the career path and have the calling, are going to be the most passionate and are be able to drive this program within your institution. So what does it take to actually build a good team? You have to have a group that's very knowledgeable, and oftentimes it's the champion, so referring to the person that's actually in red to say they're the ones that are actually going to provide the knowledge and disseminate. They're basically very good communicators, and the people that are on your team have to be good communicators, because if they're not receptive to new ideas and aren't able to deliver the information outside of their own unit, it's really going to be a challenge. Empathy, I think we all need to understand the relationships that we have, and working on a ward, a general medical floor, surgical floor is much different than critical care or emergency medicine. And really, I think it's very helpful before you start one of these programs, if you have the team, that actually go up and sit on that unit for 10 or 15 minutes and see the workflow. You really have a greater appreciation for what happens outside the ICU, and sometimes I think we really don't appreciate how hard people work outside of our critical care environment. And again, when things go right or things go wrong, I think we need to support the team. So how does this affect nurses? And how do we get this nursing team to buy in? I can tell you that this was a valiant effort to get nurses to do this work. We really asked them to do work that we actually didn't even think was possible. It was just a grandiose idea, and we weren't really even aware of whether this was going to work. And we initially thought, we're all going to hit a brick wall with this. This is not going to work. But this is actually a question and an answer. So why are we doing this? And this is really what's actually driving the nurses. They want to know why we're doing this. So if we fail to give them information as to why this program is in place, the program's not going to do very well. And I learned this very early on. When we collaborated as a team in our hospital, we had very high-level, motivated folks on the team, but we really failed to include the people that were actually doing the work right up front. And, they were doing what we asked. They were trying, they were screening patients, but we really didn't give them the background information as to why they were doing this. And nurses really, they want the story. They don't want to just be told to do a task. They want to know why they're doing this. So we started to give them information. Sepsis has changed over the years. In 1999, it was number 10 on the list of the top 10 diagnoses for Medicare patients. And in 2013, it's number 2. So we're starting to build some credentials as to why we're doing this. During the years of 2000 to 2010, there were a number of diagnoses where the mortality actually decreased, but unfortunately, we still have an issue with sepsis. That was the only diagnosis in this list that had a 17% increase. So now the nurses are starting to see we do have a problem, and I see these patients every day, so now it's starting to resonate. Now we're telling them not only is it a hospital-wide problem, it's a national problem. It's specific to these units. It's specific to medical surgical units, and they have the highest mortality. And this data was from the Surviving Sepsis Campaign. We looked at patients who were admitted to the ICU and their origin prior to ICU admission. And you can see patients that are on the wards, even though there's only a small percentage of them, 12.5%, they have a very high mortality. So again, they understand this. These are their patients. But then we also need to say, okay, in their minds, they're saying, okay, this is a problem for everybody else, but how does this affect us? And you really need to pull the story from their unit to say, last week we had a 70-year-old grandmother who died from sepsis in our hospital. This is what we did in a timely manner, and these were the efforts that were delayed. So if we were able to draw lactate and blood cultures, we did a great job on that, but we failed to give antibiotics in a timely fashion, or we only gave the patient 500 cc's of fluid, and we kept delaying care. 24 hours later, the patient's in the ICU. This is what we could have done different for that patient. And then tell them what the outcome was. The patient wound up in the ICU for 5 days. They came back to your floor. But that really delayed the patient's progress, moving forward. Maybe we could have done something different on the floor. So what do we need to do? The goal was to screen every patient, every shift, every day. And this was the mantra for this particular program. And you can imagine we're asking nurses who have 6 to 9 patients to do something else, to add something else to their workflow. And it was really a lot of work, but I can tell you once you start to build a story, they understand why we're doing this. The other thing was we realized that nurses outside the ED and the ICU think differently. They don't necessarily have the same critical thinking skills. So part of this program was helping them to understand how to think critically, put the pieces together, not to be as task-oriented. And you can imagine taking care of 8 or 9 patients, you have to be very task-oriented in order to get the job done. They only have so many hours, before they have to give their medications. They have to assess 9 patients in a very short period of time. It's a very hard environment. So again, this was a challenge to ask them to do that, but they did meet the challenge. This was a screening tool that we used, and this screening tool we've been using in the Surviving Sepsis Campaign for years. And basically, we're looking at, does the patient have a suspicion or confirmed infection? Do they have at least 2 signs and symptoms of infection and at least 1 organ dysfunction? Again, I'm still trying to learn the definitions, but I did modify this slide here. So we're basically trying to teach the nurses what to expect in a patient that has sepsis. So how do we actually do that? Some sites actually use that paper screening tool that I just showed you, and they collected on every shift, every day. The nurses completed those forms. And then we had other sites who actually had the ability and had IT support where they incorporated that screening tool into their electronic medical record. I can tell you in our hospital, it was a sequential effort. We actually created a tool very similar to the initial paper screening tool into our the nurses' progress sheet. And we thought that that was going to be great because they could just do like a little checklist. But when we actually had them do it, I realized that it was not efficient at all. They thought it was great because they said, oh, this is fabulous. But then I realized they have to go into the lab section to see if the patient has a high white count. They need to go into the vital signs section to see if they have an elevated temperature. So it really wasn't efficient. So we actually modified that, and I'll show you as we move on how we actually got through it. We also realized, like I mentioned, that the nurses on the floors communicate a little bit differently. In the emergency room in the ICU, I think that the nurses feel very confident in their skill set and talking to physicians about signs and symptoms of things, and particularly with sepsis. And maybe they'll hang fluids and then tell the physician, listen, the patient's hypotensive and I hung fluids, can you write an order? The nurses on the floor didn't really have that same level of confidence. And I don't think it's just in our hospital. We did see that throughout the collaborative with over 60 hospitals. So we recognized the fact that communicating with the team was important. So this is just an example how I mentioned to you that in our hospital we had the screening tool, but then we also went to an electronic alert, and we actually built the S-bar into the screening tool. When nurses call the physicians, this screen is already on the computer, so they can actually report right off of here. You know, the patient has a suspicion of pneumonia. This is their background. The history will pop right up into the sheet. Their most recent vital signs will be there, their most recent labs. So they can actually go through the situation background assessment. And then it actually gives recommendations. So if the screening tool alerts the nurse that the patient meets the sepsis criteria, then it'll give recommendations for sepsis. If the patient met the criteria for what we had as severe sepsis, there were recommendations for that. And then it'll also allow the nurse to actually order labs from this particular screen. So this has helped us significantly, and it really cut down the anxiety for the nurses in giving this information to the physicians. And then actually the collaboration that was built over time, it was about 6 months before the nurses really felt confident in their ability to call the physician. I mean, they were somewhat hesitant, and there were some nurses that never felt comfortable over that 6-month period. But in our hospital, we actually decided that, the nurses were able to communicate well, and we were actually going to initiate a nurse protocol. So we have initiated a nurse protocol where they're able to order some labs. They can order a lactate, and it actually cuts down on the time. So when they call the physician now, they can say, this is the most updated labs that we have, or, increase the vital signs to every hour, that sort of thing. But there's still an element here where they still need to communicate with the physician, but it helps them move the program a little bit more forward. So how do we actually work together? For Christmas, one of our attendings in the ICU, Dr. Treziak, gave me a book. It's called The Happiness Advantage. And initially, I'm thinking, oh, my goodness, where am I going to find time to read a book? So I decided every day at lunch I was going to read a little bit of this book, and it really had a lot of insight into life and work happiness. But this kind of played into what we were doing here, that if you're initially starting a program in your hospital, I think it's a challenge to start hospital-wide. When we initiated this program, we only started on one unit, and build on the success of that unit. And I think that was probably the best way to do this because it was a lot of work. So I think if you channel your effort to one particular area, build on that success, you'll see that if you have a 10th floor where you have a north and a south, maybe you'll start on the north side and then transfer to the south side and move down. But I think from a staff standpoint, you can build on those successes because the nurses on the 10th floor can talk to the nurses on the 9th floor and said, oh, we had the same problems, but you'll work through it. In 6 months, this will be a piece of cake. So I think building on the success of this program was helpful. And then when you set goals, I think it's important that we set reasonable and manageable goals to achieve wins. So our initial goal was not are we actually improving the management of the patient, but are we able to screen every patient every day? And are we able to get the nurses to be compliant with that process? So we really looked at compliance with screening first, and then we recognized those small changes where the mortality went down, decreased ICU admissions from that particular unit. So again, I think you need to set your goals small. Once they achieve success, they'll actually continue to move forward, and we'll try to move the program forward as well. So I'm just going to end with this slide. I think it's actually a good summary of the process of building a good team. I think coming together is the beginning. Keeping together is progress, but working together will build success. Thank you.
Thank you, Christa. So Christa gave you an excellent summary of the screening part of the initiative that we launched over the last 2 years. It was actually a multifaceted initiative that involved collaboratives around the country. We had 3 separate collaboratives running on the East Coast, the Midwest, the West Coast, and actually an additional collaborative using Adventist healthcare system. And you'll see during the course of the remaining presentations that screening, a critical part of this work, was just one part. There's also engaging teams, getting the cooperation and buy-in of nurses and physicians alike, hospitalist groups, and then how to protocolize care after that time to make sure that we deliver the right care to the patients, and we ask the hospitals to do that. And finally, a key part of our work was to measure results, and Dr. Levy's presentation will speak to that. So with that sort of overview, I'd like to introduce next Dr. Richard Beal. He'll speak to strategies in using rapid response teams. Dr. Beal is a professor of intensive care medicine at King's College in London. He is a consultant in intensive care medicine at Guy's and St. Thomas NHS Fund Trust. He's been the ESICM representative to the Surviving Sepsis Campaign for the past, since 2004. Some of Richard's interests include sepsis, hemodynamic monitoring. He likes to watch the planes take off and land at Heathrow Airport on the weekends. And indeed, he likes sunbathing in Nice throughout the summer.
Well, thank you very much for that. Well, it's a great pleasure to be here. I remember my glasses this time. Last time I was on a stage like this, I forgot to stand up with the glasses, and I couldn't quite read what was on the screens, and I had to ask Mitchell to help me, which was an embarrassment, as you might imagine. So I'm going to give you the perspective from the other side of the pond on this particular general approach, and I hope that some of the things that I will say resonate with your own experience. Over the years that I've had the privilege of coming to meetings here in the US and getting to talk, it's become apparent to me that in spite of the fact there's a strong belief in both our countries that the US system and the NHS are very, very different. In fact, they're much more similar than you might think, particularly in terms of metrics, payment mechanisms to drive quality, standardization, process control, and so on. And as a European society member, I often find it's much more difficult to find commonality with the French, say, than it is with practice over here. Now, we have the same problems everywhere, don't we? This problem of increasing demands for critical care provision, too few staff, we all have that issue, and limited resources. And it really doesn't matter which economy you're in. If we carry on the way we are, we either have or are running out of resource. So that's one big challenge. We can't just go out and ask for more anymore in the expectation that we'll get it. The second thing, of course, is that the early recognition of sick patients is the bedrock of effective and rapid response, and everything that we've done with the Surviving Sepsis Campaign has been predicated on that early recognition and early intervention. And, of course, we've seen the benefit of that over the years. So there are at least three key questions. One is, how do I identify acutely unwell or deteriorating patients who are outside the critical care envelope as early as possible? In the UK, we have our National Institute for Clinical Health and Excellence, which is quite similar to the Joint Commission here. And at the moment, sepsis is receiving a lot of attention. Guidelines for its management, which will be mandatory, are being developed. I'm privileged to be on the task force doing that. There's a lot of political support for doing it, much as the same fashion as there is here in the US. And interestingly, the scope of this initiative is focused almost entirely outside the ICU. The general view is that once patients are in the ICU, from a health system point of view, the intensivists sort of know what to do. They'll get the evidence. It's their expertise. Let them get on with that. The challenge is on the hospital floor. It's in the emergency department. It's in the pre-hospital environment. Those are the places where you need to recognize these patients and intervene. The next thing, of course, is how to respond as rapidly as possible. And who's going to do it? Both in terms of who's got the manpower, womanpower, resource to do it, who has got the skill set to do it. And then finally, of course, does it make any difference if you approach these things? So deteriorations are usually preceded by changes in physiology, and this has been known for a long time, and various studies have picked this up. When I was a resident, it was normal in critical care to be called for that patient who was having the unexpected sudden respiratory arrest, who, of course, as we now know, was really just that patient who had been deteriorating unrecognized and had finally used all their physiological reserve and collapsed. And so the whole concept of early warning teams, rapid response teams, critical care teams going outside of the critical care without walls, all these things began to be developed, and various studies, as you know, have looked at this. A particular one of great interest was this Australian study. 23 hospitals, ICUs, around Australia, looking at the introduction of a medical emergency system in a cluster randomized trial. And this is methodologically the most robust attempt to address this particular issue that's been done, really. And interestingly, you can see that the MET system greatly increased emergency team calling, but does not substantially affect the incidence of cardiac arrest, unplanned ICU admissions, or unexpected death. Well, this has been extremely controversial, and given that many of us do this now, the fact that they couldn't show it is also slightly a problem. The criteria that you use, of course, are these basic physiological measurements, our basic observations. And notwithstanding this study, these have been codified in the United Kingdom into a national early warning score. Interestingly, this study, as I say, had some challenges in that much of what they found was very close to the intervention time. But by the time it was published in The Lancet, in the UK at least, this journey had already started, and most hospitals were starting to introduce these teams and weren't going to go back. Another issue, of course, is at that time, and still today in many places, it's this sort of chart, paper chart with all its weaknesses, that drives what happens. And it can be very difficult for anybody to pull out information in real time on a hospital ward or floor to intervene in a timely fashion, let alone after the event to go back and understand performance. So anyway, in the national health system, we are now all mandated, we must use this. Every hospital in the country must use this for all acute patients on the hospital wards. So all inpatients have this done. The background was all about early detection and timeliness and competence, and I won't bore you with the detail, but it's a nice summary of the challenges. And this is the system. Pretty much like the Muse score, relatively crude, not terribly scientific, really, just the standard variables here and scores on either side of normality. It's a point estimate. There isn't really a great deal of sophistication in the weighting on either side, and if anything, it's likely to be oversensitive. But that's accepted as being better than not picking things up. These are the various thresholds: clinical risk of low, medium, and high, and these tend to drive escalation. And, of course, you need to put in place hospital responses that will manage this. In the era of paper charts, which many British hospitals still have on their wards, then examples of charts like this are used that facilitate getting the right score and avoiding error. And we've now moved off paper charts onto electronic charts on all our hospital wards. But when we were still with this, the way we got good performance was our chief nurse herself and her deputies decided that every Friday was a day when all nurses of all seniority were back on the floor. And the first thing the senior nurse had to do in his or her area of responsibility was check that this was being done properly every week. So a lot of institutional effort went into doing it. We have various people setting standards we must adhere to. These are the standards for London that commission critical care and, in this case, acute medicine and emergency care and surgery care on the wards. And you can see here that all patients admitted acutely to be continually assessed using the National Early Warning System. So this is not an optional thing, and if you don't do it, you're penalised heavily. Now, when it comes to do these things make any difference, interestingly, a nice issue of Intensive Care Medicine looked at this recently, and one group said, rapid response team, yes. Another group looking at the same things, no. And interestingly, this group from King's College Hospital, our partner hospital in our Academic Health Science Centre, a member of King's Health Partners, Ritesh, who wrote this, his boss wrote this one. So trumped the situation. Rapid response team, improve outcomes, we're not sure. And this is actually an extremely insightful, if you like, a more grown-up review of this. Julia Wendon and Ronaldo Bellomo. And this is a little bit of text from it, which says, however, despite the above considerations, the key question may well not be, are we sure or not sure that rapid response teams work? The key question may instead be, how sure do we need to be that they work before we introduce them? In the commentary, we've used a legal analogy and have argued that we are not sure about their effectiveness beyond reasonable doubt. However, the law also uses different levels of evidence according to different situations, and for civil cases, damages are paid to the plaintiff if the preponderance of the evidence supports the case. In this case, it's clear that the preponderance of evidence is supportive. And they also go on to say whether such evidence for our rapid response teams is sufficient is ultimately a question that can only be addressed locally. In this regard, most Anglo-Nordic countries have already voted with their feet. And that's right. This has happened. It's not going to go backwards, whatever the evidence base may say. They also did this retrospective analysis of the Merit database, which pulls out some really interesting insights as to the sort of things that happened when you introduce these sorts of initiatives. The most common trigger was that staff members were worried about the patient. Such a powerful thing and not something you can codify, but that sense of things not being right by experienced nursing staff is crucial. Now, of course, this is against a background where, and it's not just the US, we in health have not seen any improvement in productivity. So we have to organise ourselves differently if we're going to deliver these things. So I thought I'd just spend a few moments telling you about our own local challenges as a tertiary academic general hospital, 800-odd adult beds, about 10%, slightly more, as adult critical care beds of one sort or another, so not too different from the US situation. Fairly busy ED, quite a busy surgical program, and very good performance around acutely unwell patients. It's very difficult to die on our wards unless the intention is that end-of-life care is the preferred route. So whenever we do, we mustn't make this worse. But we have these problems: increasing emergency pressure, insufficient critical care capacity. The last few weeks, we've been cancelling 15 to 20 cardiac surgical cases a week because of emergency pressures through flu and cannibalizing planned elective surgical capacity to deal with emergency workload. The National Health Service has very real financial constraints, and although we need and will build more capacity, it takes too long to bring it online, so you have to do something now. So we need a new approach to how we work. Now, I've said that we have news embedded in all our charting, and we've recently achieved full electronic charting. And currently we have two levels of response. We have this team of so-called site nurse practitioners, very senior and skilled nurses, mostly with a critical care background, who respond. And then we have a critical care response team. Alerts are flagged locally into this SNP team, and then referrals are either, if the patients are at the high end of dependency, to the critical care response team. What we've now decided to do is combine these two into one. So we'll have 40-ish senior critical care trained acute nurse practitioners who will be the primary response to support on the ward and to initiate treatment and to escalate as necessary. They have a high degree of training and are all advanced practitioners with prescribing rights. They have line skills. A number of them can intubate and so forth. They're supported by full-time by a critical care resident and a consultant or attending, technical support from critical care, and crucially, this whole combined structure has been given to critical care to manage. Now, you might think that's great. I think it's the right thing. I would do. Ultimately, it's under my managerial aegis. But it's quite interesting. Once upon a time, physicians and surgeons on the floor would have say, no, we don't want to give up our patients. We don't want to lose continuity. These are real issues for us. That's gone. Now they're only too willing to have this happen and work very collaboratively in a shared way without any sense of threat to deliver this. Actually, where the resistance comes from is from some of the critical care physicians. It's not intellectual resistance. They all think it's a good idea. But at a personal level, not everyone is comfortable leaving the ICU and going out onto the floor, going out and seeing patients where you don't have the same resources, you have less information, going to the ED and so forth. And that's a challenge. What we're going to do is use our new telemedicine control center, which is in our hospital rather than remote, as a sort of generalized control center, a bit like a control tower for the hospital, if you like, and enable all the hospital systems so we get a single overview of hospital-wide acuity, 24/7 single point referral. We'll link it to critical care bed management and try and use this as an integrated, fully multidisciplinary approach, bringing all those people together as a shared resource and see if we can do things better than we're doing it now. Now, of course, sepsis is an intrinsic part of all these early response things, and you can't have two separate structures. The most common driver for the deteriorations on the ward is, of course, sepsis. This is our current sepsis screening tool, which we're just working to embed in our new electronic systems. And, of course, there's a recognition and then actions. And one of the challenges we're going to have to face, of course, is just modifying this to operationalize the new definitions as we take those on board. Surviving sepsis-based screening tools are standard in pretty much all NHS hospitals. And, as I say, it has to be completely embedded and in order to let us monitor performance and improve further. Now, the last couple of moments, I just quickly want to touch on better use of technology, because, of course, that's another key part of this. This is an approach called Vicentia that has been developed in the UK. I don't know whether it'll ever get mainstream. It's actually been used in Pittsburgh as well, developed by Oxford University, and I've partnered with the people who develop it for subsequent research. It uses a pleth. This was an attempt to do it in a mobile sense, but a pleth to get SATs, pulse rate and respiratory rate, a clever mathematical fusion model, and actually it's a derivative of the technology that's used to monitor aero engines in flight. The first company to have this were Rolls-Royce. It's the sort of stuff that was switched off in the Malaysian airline disaster. And this team at Oxford developed fusion algorithms for monitoring jet engines and have started to apply it in the healthcare environment. And we've been working to try and move this to the next level with them. But in any event, it certainly picks up patients sooner than standard alerting and potentially gives you a more sophisticated approach if you can get the sensor data into the system than those current rather rigid news scores type approaches, and it will pick up what's going on before patients cross conventional thresholds and before MET teams are triggered. Wearable sensors is something else that's on the horizon, and a lot of people are pushing them. They're not quite ready for mainstream, although they're almost there, and I know there are 1 or 2 centers that are making them work. We ran a study recently where we took 220 cardiac surgical patients and monitored them completely from the end of surgery right through to their discharge process, electronic patient record, but also full data capture, including waveform capture when they were tethered to monitoring, but then when they were ambulatory. But we had to use old-fashioned telemetry to do it for the final ambulatory bit, because the wearables were not quite good enough. Nevertheless, what it shows you is if you have continuous monitoring, this is one patient, these are the fixed routine observation points, you will pick up stuff earlier. The question is how to use that and embed it in your approach and derive value. Here's an example of desaturation where the same thing is true. And it's hardly surprising, but of course you have to operationalize it. Interestingly, in terms of the coverage we got of any signal, you can see we were covering, about 70% of the time the ward stay. And this is the duration of the time on the ward that the stuff was worn. But when you look at the coverage in terms of individual signals, there are clearly technical issues here that you have to struggle with, and you have to manage data quality, and you have to figure out how you're going to deal with false alerts and all that sort of thing. And that's without even getting into deriving respiratory rate from these things. So to conclude, all our health systems have the same problem, which fundamentally is a mismatch of demand versus resource. But general screening and early warning for inpatients is clearly coming. It's intrinsic in the technology we use. We hope it will help with this if we do things properly. Sepsis has got to be embedded in it, not a separate system. And I think success will be a hugely powerful thing, but will be a combination of process change and technological change. But it should really make a difference if we do it right. Thank you very much.
So I'd like to ask Richard to stay right here. He has an early flight to catch, and we want to be helpful to accommodate him. I hope he might be able to take some questions. So if you have some, please come up to the microphones. I guess I'll start then, Richard, to ask you, with the development and the use of news in your facilities across the NHS, and your graduation away from paper screening and so forth, do you feel that there's been a large improvement in decreasing the number of inappropriate or false positive screens? Has that been a better experience for providers?
It's a big problem. When we went from the Muse system to this news system, which isn't very different, but the thresholds were slightly different, we had a step up of about 30% in false positives. And that senior nursing level we was absolutely crucial in triaging them and starting to educate staff as to what was and wasn't reasonable and support them. So you absolutely can't, I think, at least at the moment, do it just on a technological basis. So I think that is a challenge with that. The other problem, of course, is observations, at least in British hospitals, are often taken by healthcare assistants. We're not at a stage where, even in places that have gone paperless, not everyone, and we certainly haven't across all our wards, made the jump of the spot check device automatically populating the record. There's still a lot of manual entry goes on. And so the person who's doing that might be a healthcare assistant who has a lower level of training and experience than a registered nurse. And so the mind that sees and assimilates is different. And so as you change these things, you have to figure out how do you do it in a way that doesn't lose that essential contact that goes back to that issue of staff just being worried, which is often a key element of this.
Mayor Sagi, New York. We all understand that the management of sepsis is time sensitive, particularly with regard to administration of antibiotics. Yet it's still unclear to me, how do you determine TimeZero in that sepsis timeline? And I guess the follow-up question would be, how often would you do the screening?
Well, the issue of TimeZero has been a difficult one from the beginning. What we've always tended to say is that it's really the first time when you could, and therefore arguably should, have known in terms of the measurements you make. It's not the time you do know, because you want to drive performance improvement. But even if you use that sort of definition, clearly you may not have measured until sometime after the event. The patient may not have presented until sometime after the event. So there are issues with that. But from a practical point of view, you have to take a view in your institution how you're going to do it. And basically, in the ED, for instance, we would say it's the time of presentation and initial triage. That's when the clock starts. It may be harsh, but it's the thing that was most likely to drive performance improvement. And on the wards, you want to say it's the first time when conceivably you could have known. More difficult on wards because you've often got to go back for chart review. Continuous monitoring, of course, might pick it up sooner, but it might also throw up challenges. And that's where the technological developments are going to have to take us to get that balance right.
Matt Sherbeck, University of Chicago. I'm interested to hear your opinion regarding unifying the screening for sepsis, in particular in relation to the new definitions. Of course, we had SIRS, and then now, particularly for ward patients, we have potentially the use of QSOFA, and then you're already using the news on your ward patients. So what's your strategy moving forward with all these different options, and are you planning to just use the news, or how are you going to incorporate the other variable algorithms?
I think this is a challenge that we're all going to face. With the nice sepsis guideline process that I've been involved with in the UK, we were working for the guidance we're going to put out, which will be mandatory in UK hospitals. We've been working to try and understand how we can align these different definitions and still have something that is operationally robust, reasonably simple, deliverable, and doesn't confuse. Of course, the issue in the new definitions is to identify infection and then apply QSOFA. So, if you like, the slight twist is going to be what are you going to use in terms of identifying infection that you can codify, capture, and count. And we will inevitably still end up using the normal clinical signs of infection as we did before, which, of course, are not so different from SIRS in some respects. So I don't think it'll be as much of a challenge as it might appear if it's done sensibly, but it is this key thing of operationalizing it consistently in a way that does not undermine what we've already achieved, but gives us the value intrinsic in the extra subtlety within the new definition. And we'll just have to see how that works in our different healthcare environments. When you change something like this, it's a process issue as much as a scientific issue, though. It does present significant challenges, and underpinning it all, we'll have to be sure at the end of the process that we have continued to improve rather than inadvertently slow that improvement down.
My name is Marnie Chandler, and I'm from Intermountain Healthcare. I'm intrigued by what you said about using your telemedicine unit to help observe, I think, these types of alerts and deterioration in patients in your facility. I was wondering if you could expound on that just a little bit. We have a telecritical care program and are trying to expand into areas of meeting and assisting patients with critical illness outside of our, the typical ICU model that we have had in the past.
So obviously Intermountain has a long history of being very sophisticated in terms of its use of informatics, but also its process management, and has achieved formidable outcomes as a consequence. And we're just at the beginning of launching our own telemedicine initiative. And because of various challenges, our hub, will be sited on one of our hospital sites rather than remotely. We may change that in the future, but right now we'll have that. So we thought we might as well use that as the control center to coordinate all these other things and run our system as well as using the particular ability of the telemedicine we will have a number of carts that we will explore deploying to particular patients alongside these teams. We have to see how that's going to work, because we haven't done it yet. We're just setting up to do it. So I think we just think that ultimately, rather than these being separate technologies, what we're trying to do is turn our hospital into an airport with a control tower rather than one without.
Great. Thank you so much, Richard. That was wonderful. Appreciate your perspective as always. And so moving on, I'd like to have the pleasure of introducing Stephen Kinch. Dr. Kinch is Vice President in the Office of Clinical Effectiveness at Adventist Healthcare System. He led the system-wide effort in the Adventist Collaborative. Fortunately for the sepsis campaign, Dr. Kinch is also a general orthopedic surgeon, and since many of my colleagues are aging, they'll need hip replacements and knees in a short period of time, and we'll be calling on Dr. Kinch for his help. Thank you.
Thank you, Sean, very much. As Sean indicated, I'm a general orthopedic surgeon, principally doing knee and hip replacements and sports medicine. So if you can teach an orthopedic surgeon about sepsis, you can teach anyone about sepsis. So we have a fairly large system at Adventist Health System. We're a not-for-profit, faith-based system. We have 44 hospitals in 10 states, 78,000 employees, and encounter roughly 4.7 million patients annually. We became involved in the Phase 4 of the Surviving Sepsis Campaign through a phone call. We were trying to figure out how we were going to move our progress from our ED focus around sepsis to our inpatient area, and we're beginning to figure out what sort of clinical accountability should we develop, what should be the goals, how should we do this. And we made a phone call, and it was a very fortuitous phone call because it was at the right time, and I thank Mitchell and the Society for allowing us to come into this work effort. It was very, very rewarding for us and for our patients. This is a little bit of a workflow chart that I want to point out two key elements of. And that is this first element, screen every shift within 2 hours of start of the shift. And then this element over here, which says Cerner Sepsis Alert Fires. We are a Cerner shop. We have Cerner deployed across all of our hospitals. So we deployed this and reported information on this based on the screening, the nurses screening and entering this information into the database. However, we were able to track in the background what was happening with regards to the Cerner alert that was programmed into all of our hospitals. So that gave us some interesting information. And also down here, the positive screen was confirmed, and we did involve in all of our hospitals a sepsis team or a rapid response team, or even in some of our smaller hospitals, just the critical care nurse that responded to the bedside at the request of the staff. Going on to treatment, and I heard a question about TimeZero. This illustrates how we identified in the different scenarios TimeZero. You'll see there's one here that says if the screen is positive, hypotension present, TimeZero. You'll see another one here, same issues up top, but then if lactate is 2 to 4, and then over here to the right, TimeZero, lactate greater than 4. So there were different, as was mentioned earlier, when you had the information that indicated that the clinical criteria for sepsis were met, that formed your TimeZero. I'm here mostly today, though, to speak to you about our experience at the bedside and our nurses' experience. So As an orthopedic surgeon, I hope I do our nurses justice. This is where we started, and I want to focus on the second bullet. It takes too much time to do it. It's another thing to do. Even when we do it and we talk to the doctors, we're not often sure that they're going to get the idea of what's going on and do what we wish. Not too uncommon for many initiatives. It is a really painful process. You have to hold each other accountable. This is social behavior. Screening at its heart is social behavior, so you have to hold each other accountable. We found that developing the tools that made it easier were very, very critical, especially nurse-driven protocols that have to pass, as you know, through your medical executive committees. Some of our hospitals developed these little badge buddies, education videos. You have to be pretty creative, but leave it to a nurse to be creative because they are fabulous at that. To where are we now? A couple of things I want to point out here. On the units which participated in this collaborative, they became the sepsis experts of the hospital, and they garnered the respect of their peers. Wonderful, wonderful result. I want to turn your attention here because we've heard some comments about electronic alerts, and as I said, we use the Cerner alert. Very often, and I don't have a specific number yet because we're still looking at the data, but very often the transition to sepsis was caught before the alert fired. And, of course, we had many patients in this one particular hospital's results that I'm using here who were greatly impacted by the screenings. And look at this last comment by our nurses. We've developed skills that not only impacted the patients from the collaborative, but all the lives we will encounter as we incorporate this knowledge into our practice. We found fortuitously found many patients deteriorating for other reasons other than sepsis. We found evolving MIs, we found pancreatitis, we found evolving sickle cell crises, just to name a few. Very, very helpful for many different reasons. So what are they saying now? Now the screens are seen as very valuable. They're doing them every shift or with change of shift. We have the alerts that fire, as we said earlier, late. We catch them first. And you all know how this works in the hospitals, right? So on the med-surg units, your patients are assessed every 6 to 8 hours with their vital signs, usually by a patient care technician, sometimes by a nurse. That person goes around to 8 to 10 or 12 patients and then downloads or enters the information on that patient into the computer. So by the time they get around to doing that, when something was taken and when it's actually encountered or encounters the EMR, some time has passed. So everything isn't roses. This is what the screening tool utilization compliance looked like at one of our hospitals. We asked all our hospitals to meet a 97 to 100% compliance on day shift and night shift. If the compliance dropped, the sepsis lead for the unit would come in, re-educate the staff, and look to find out what was going on. And you know what happened in this case? This was a situation where there was high census and there was a high occurrence of travelers and floats who didn't know exactly what the process was, and so screening dropped off. It picked up very quickly afterwards when those folks were educated. Sawtooth Pattern. This is another pattern of screening compliance. Just to tell you that anyone who shows you a straight line graph is either deluded or outright lying. Power note, documentation is critically important. a power note was developed by our hospitals for the residents in one of these hospitals to complete their notes so that they had a standard way of documenting what they saw and what they did. Critically important, because we know that handoffs and transitions are problematic shift to shift, provider to provider, so this standard approach was extremely important. Deep dives, an IHI technique and extremely valuable. Take your last 2 to 5 patients who develop sepsis on the unit and do a deep dive. Look at what we found out. RN caught this case, positive ID from Cerner versus RN assessment. RN caught this case, RN caught this case, Cerner and RN caught these cases. You can see what happened. One patient died, 80% were discharged home. Another deep dive at a different hospital. A hospice patient down here, otherwise 80% discharged home. Positive ID from Cerner versus sepsis, RN, 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 RN. If you think you can do this exclusively based on an alert, our experience would say you're not going to catch them all. And when you do catch them, you'll catch them a little bit later than you would have otherwise caught them. I won't spoil Mitchell's presentation, but I will share with you one key point. What excited us so much about this opportunity was that much as the national numbers from the Surviving Sepsis Campaign database showed, in our ED, if you were detected with severe sepsis or septic shock, you had about a 24 to 25% mortality rate. By coded data across our hospitals, non-POA, you had about a 36 to 38% mortality rate. Not too different than the Surviving Sepsis Campaign database, which showed about a 40 to 44% when you originated your sepsis outside the ED. Very similar. Mortality rate on the collaborative units at the conclusion was 17.5%. Patient stories. The power of story. This first patient is a behavioral health patient who was depressed, laying in her bed most of the day. 2 nurses came in to try to encourage her to get up, eat a little, and talk. They had received some training on sepsis and sepsis criteria and the symptoms. She appeared a little disoriented, and they decided to do a screen instead of just thinking she was having a reaction to some medications. She has a positive screen, was moved to the ICU, and survived. Not your typical patient that you might think you would detect sepsis in. This is another patient's story, and I want to just highlight 2 elements of it. The 3-hour bundle was met, no rapid response was needed, and the patient remained in the PCU. There was a sepsis alert fired later, but this patient was caught by the RN screen first, and the patient survived. I want to talk to you about a concept I called brushfires. So when nurses get a hold of something, it's wonderful. And this was what happened in this case. A med-surg unit on the 3rd floor started finding out, and this was a young nurse, started finding out what was happening on this other unit, this PCU unit, and they ran with it. They had some at the bottom here. They had some new nurse residents that took on the validation of screenings, performed the surveys, and they were greatly successful, 76% positive from the staff. So this was what I call a brushfire spread. You heard about it, you grabbed it. This passion that this charge nurse had from her experience is absolutely contagious. The RN charge nurse on the med-surg unit was curious when the patient became positive. Upon chart review and review of the screens, she realized a few of the sepsis screens had been missed being performed. And this actually missed an opportunity to catch a patient earlier. She took this to her unit council, became relentless in her message, and they ran with it. Barriers and challenges. Educational deficit was key. I cannot stress that enough. I was amazed to find out from our nurses and our physicians how little they understood about this disease we call sepsis on the inpatient units. Mind you, these are general inpatient units, not the ED. The ED was pretty spun up. The ICU quite spun up. It was the units. The level of understanding of the spectrum of this disease and how it presents really wasn't what I thought it would be. And I think that's pretty emblematic of many other hospitals. The paper screening tool was way too cumbersome. Physicians are still reluctant to administer the proper amount of fluids. And this is a condition where you have lots and lots of screens and very few positives. So it's a very difficult thing to keep and maintain momentum, as Christa mentioned earlier. We have a system-wide spread process in place now. This is basically how we sort it out, and we changed that first box from detection to suspicion, the second box to detection. So essentially we want suspicion, detection, and then treatment. Suspicion, detection, treatment. What are we learning? There are wide practice variations once sepsis is suspected. Post-sepsis huddles are extremely helpful. We did not remember often enough to obtain a second lactate without a reminder, so we have now instituted a discern rule that fires a reflex lactate if the first lactate is a certain level. Know what's happening? They're getting calls from the lab saying, do you really need this repeat lactate? Oh, it continues. Let me leave you with some quotes. These quotes are absolutely amazing, but I think one that I love the most is this fourth one down. Nurses go through a lot. So to have something impact this nurse in such a profound way is just absolutely amazing. We do want to create regional dashboards now, so we'll begin to see we have 7 different regions in our country, in our company, and so we want to see how this is going across our company in a more effective manner, just tracking that. This is a picture of our electronic form. What I want to point out here is, to Christa's point earlier, these first 2 boxes, 3 boxes actually, self-populate with critical labs and other information over the past 12 to 24 hours. So it makes it easier for the nurse to use this form than to do paper and try to track down where all these lab results are. Then this is a smart form. So if they check off here that 2 or 3 or more criteria are met, this section opens up. If the criteria aren't met, this section never opens. When this section clicks off, this section then opens for organ dysfunction. So it's a smart form. You got to make it easy, and you got to hardwire it to make it sustainable across the large system. Going forward, these are the next frontiers, and you've probably talked about this already. County EMS, we have in the South Denver market and around Orlando, county EMSs that now are treating what they call medical shock. EMS providers understand shock. Now they're going to understand what medical shock means and how you need to get these patients resuscitated early. Very, very important. And I'll leave you with this statement, which might seem a little Pollyannish, but I think it still deserves mentioning. It only takes one person to make a change. I mentioned the Brushfire spreads, the enthusiasm, the impact that it has on a nurse. who's been practicing for over 18 years, how important this means to them in their personal lives and how they can help patients. We have figured out at Adventist Health System that if we successfully migrate this screening protocol out across all of our hospitals, we have an opportunity and are able to get the mortality rate that we got on our collaborative units. We will be able to save a little more than one life a day, every day. Thank you.
Many thanks to Dr. Kinch. I have to say I'm quite in admiration of the learning approach he takes to this journey and the reevaluation that his hospital system has taken at each step of their journey and the deep dive work that they've done as well. That's just the way to get this accomplished. I have the pleasure of next introducing Andy Auden. Andrew is a hospitalist, and he's participated in the Surviving Sepsis Campaign and IHI initiatives for some time. He's assistant professor of medicine at Washington University in the School of Medicine in St. Louis. He's an active member and leader in the Society for Hospital Medicine. And we're delighted to have Andy here today to tell us a little bit more about how hospitalists can engage this program and push this along in our hospitals.
Thanks, Sean. So as I mentioned, I am, there we go. All right. Apologize for that. My first disclosure is that I thought the track wheel went the other way. So we'll work with this. But I do not have any other disclosures other than the fact that I, like Steve, am not an intensivist. I'm a hospitalist. So my goal today really is to accomplish a couple of things. So one is to explain why the wards are different than both the ER and the ICU. Because being a practicing hospitalist, I can tell you that there are some very important clinical and structural differences between the wards and the ICU. And then also to talk about, my second goal is to talk about the role of hospitalists in driving change for detecting and treating patients with sepsis on the wards. Because as we've seen, and as we'll see more, there's a tremendous opportunity for improving the care of these patients. They are often a neglected population, and there's really a lot of improvement that we can still drive. So I'm not going to go into depth on the new phases of sepsis that were just released yesterday. My main point of adding this slide is that even though a lot of the definitions are changing and a lot of the structures are changing, the principle remains the same in that sepsis remains a spectrum of disease severity and that patients on the wards can present with infection, they can present with sepsis, and they can present with septic shock. And that not all of your patients with septic shock are going to present in the emergency department and go automatically to the ICU, that a significant number of these patients will end up on the wards. And for reasons that I'll discuss, this represents a tremendous potential risk to our patients. So as we learned yesterday, infection now encompasses what was previously termed sepsis, and that we're moving away from SIRS. I'm not going to, again, go into that too much. I'd like to dodge many of the bullets that would inevitably come my way. But that the newly defined sepsis is going to be what we previously referred to as severe sepsis, and that is a dysregulated host response to infection causing new organ failure. And as a hospitalist, this definition really resonates with me. This is something that makes a lot of sense. I think intuitively this is what we had all thought. The one caution I would have, though, is that there are a lot of practicing hospitalists out there who are ingrained in the idea of SIRS and infection leading to being sepsis, and that practice change is going to take time to occur, and the uptake of those definitions will likely take time. And that my other point with the definitions is that this doesn't, in my mind, demonstrably change the number or types of sepsis patients that I'm going to see on the wards. What I see every day, these criteria still encapsulate really quite well. So why are the wards different? I think that's one of the fundamental questions. So first of all, unlike, at least my impression of most emergency departments and intensive care units, there's tremendous diversity of general medical surgical wards, even within the same hospital. You can have an orthopedic surgery unit that is going to be structured and staffed and function very differently than a cardiac step-down unit, which would staff and function very differently than a general medical surgical unit. And all of those factors are going to come into play. The physicians are generally very dispersed. So when I'm a hospitalist, if I'm lucky, I'll have patients on 3 or 4 different units. If I'm unlucky, it could be 8 to 10. You've got a wide variety of physicians who are rounding. Hospitalist penetrance varies a lot based on different markets, based on whether you're a teaching institution. So if you're at a hospital like I'm at right now, which is Barnes-Jewish in St. Louis, we have hospitalists, we have private attendings, we have residents, we have nurse practitioners, we have subspecialists. All of these different physicians can be, and practitioners can be primarily driving patient care. The nursing ratios are different. If you're very lucky and have a particularly richly resourced ward, you may have a nursing ratio of 1 to 4. It could be much higher than that. That's going to affect the time that your nurses have to spend with patients. Pharmacists are often remote. Your support staffing varies widely, whether you have a respiratory therapist on the unit, whether you have access to phlebotomy only during certain times, whether all of these factors can influence your ability to diagnose and treat sepsis. And the meaning of stat can vary. So if you're in an intensive care unit and you as the physician talk to your critical care nurse and say, this patient needs 2 liters of fluids and these antibiotics, and we need norepinephrine started now, that's going to happen fairly quickly. And because you have that shared understanding, because you work with people fairly consistently, it's easy to get on the same page. On the wards, I often don't know the nurses that I'm working with. I may have met them once or twice. But when I say something is stats, that could mean an hour, that could mean today, that could mean 5 minutes. It's incredible. And we don't help things either. I will not admit to this, but I've heard of hospitalists who have ordered stat collace before. Just muddies the waters. And then you've got day-night, weekday, weekend variation that tends to be more so than in the intensive care units. You've got off-shift staffing for both physicians and nurses that are very different at night than during the day. And there's some less so, but still weekday, weekend variation as well. A couple contrasts between the ICU and the wards. The ICU certainly has a high prevalence of sepsis patients. The wards, there's always been this perceived low prevalence of patients with sepsis, and this affects the readiness with which someone will make the diagnosis of sepsis. The ICU has fewer teams of doctors. At my hospital, there's usually just 2 teams of physicians. The wards, there are multiple doctors. We have 10 hospitalist teams. We have 12 teaching services. We have multiple surgical services. All of these people have the potential to be caring for patients with sepsis. The ICU is geographically localized, and don't discount the advantage that this has, or in contrast, the disadvantage that this has for the wards. When you are physically present at the bedside, or when you're in physical proximity to the other members of the care team, there's a lot of communication that can occur that would require a page or a phone call or physically traveling to a unit. and being able to do that can be a tremendous advantage. We already spoke about the nursing ratios, and I think at its essence, it really boils down to this. I view the intensive care unit, again, very much as an outsider, as a relatively resource-rich environment. And the wards, at least compared to some of the other places in the hospital, is relatively resource-constrained. And in the ICU, along with that, you can usually match resources strictly to conform with what the patients need. Whereas on the wards, you are often constrained by you just don't have the people to do something, or there are policies that state that you can't do this, or this is not possible, or you have other structural or administrative barriers that tend not to come up in the ICU. I'll go over this quickly. When I first started talking about sepsis on the wards, we really were fighting an uphill struggle, letting people know that these mattered, that these patients were prevalent. We've seen Surviving Sepsis Campaign data that around 12% of these patients were identified on the wards. If you look at all patients with sepsis, those numbers are higher because a percentage of those won't end up getting transferred to the ICU. The bottom line is there's a large percentage of these patients, and mortality, even on the wards, is going to be particularly high. This is Vinnie Liu's paper from JAMA a couple of years ago now, which showed the total number of hospital deaths, and that between a third and a half were attributable to sepsis. And the point that I like to make with this is that he looked at implicit versus explicit sepsis. And implicit was infection plus organ dysfunction, and explicit was a stated ICD-9 diagnosis of sepsis. And there was a large gap between those two. There was a nearly 25,000 death gap between the two. And to me, that represented a recognition gap, that those patients weren't being coded as such, and as a result, they weren't likely being recognized and treated appropriately. And the wards are where a lot of those patients are going to be. As far as treatment goes, we all know timing is everything for sepsis. The approach that I have attempted to take, both with the collaborative and at my own institution, is that sepsis is really like acute MI and stroke, and we really should think of it as such. And getting at this idea of low true positive screening rates, you think about how often you order an EKG on the floor and the number of times that you diagnose somebody with a STEMI. It's going to be lower than our positive screening rates for sepsis, and yet they're time sensitive and they're highly mortal conditions. As far as the hospitalist's role in this timing, because of all these structural factors and resource factors, once a diagnosis of sepsis is made, the hospitalist really needs to be incredibly engaged with the care team. They need to make sure that the appropriate fluids are given, that the various components of the bundle are executed. And I'll go into a little bit more some of the specifics of that. I won't spend much time on the 3-hour bundle. My assumption is that everyone is relatively familiar with it at this point. Lactate, blood cultures, antibiotics, and a fluid bolus for hypotension or elevated lactate. And actually go back, because this seems like a fairly simple thing to do, and we talk about bundle compliance, and you ask someone on the street and you say you diagnose someone with a life-threatening infection where they have between 15 to 40+% risk of death, and you need to do four things that are fairly common: draw bloods, give antibiotics, and give fluids. If you ask somebody on the street, they'd say, well, we should do that every time, and we don't. and we look at bundle compliance rates of 50%, 60%, and we should be able to do a lot better than that. The question is why, and it's because of that complexity. Again, this idea of lactate, I won't dwell on this. My main point with this, and when I show this slide to my hospitalists, is that even patients with normal blood pressure can have elevated mortality rates, and that if you don't look for lactate levels, you're going to miss that population of patients. So I've alluded to a lot of the barriers. These barriers can, for the most part, all be overcome, but it requires a lot of effort and a lot of attention. And any effort to improve the diagnosis or the treatment of patients with sepsis on the wards is going to require heavy involvement of the hospitalists. So recognition is a big barrier. Physicians anchor a lot. Hospitalists are certainly not immune to this. So we anchor to the ER diagnosis. We compartmentalize the pneumonia with renal failure and altered mental status as just those three diagnoses as opposed to a diagnosis of sepsis. We omit lactate because it can be difficult to draw. If you don't have phlebotomy and you need a lactate drawn within 3 hours, the nurse needs to draw it or the physician needs to draw it. And when you have a 1-to-8 patient ratio, as a nurse, that can be a difficult thing to do. As a physician with 15, 20, 25 patients, drawing blood is a big challenge as well. And the complexity of care delivery is another very specific wards barrier. So we've mapped out, at my previous job, I was at the University of Michigan, and we actually mapped out the process of getting stat antibiotics to patients with sepsis. And it was incredible how many different people and how many different processes were involved. Our antibiotics were kept physically separate from the wards where the patients were at that time. There were several steps that could go wrong and could prevent you from being able to give those antibiotics within 3 hours, or ideally less. We talked about geographic dispersal. The team dynamics is another particularly important piece. You have a lot of different people working together that don't know each other nearly as well as they do in the ER or the ICU. And that leads to much bigger challenges with getting people on the same page for this time-sensitive care delivery. And the patients are different as well. So there tends to be less frank shock, but with those with the mortality numbers that we're seeing, you have to wonder if they progress quicker or if they're just not being picked up as quickly. The infections may be slightly different. The organ dysfunctions may be slightly different. My reasoning for that is most ICUs that I've ever been affiliated with require mechanical ventilation or vasopressors as automatic tickets in. And so if you do that, you're already selecting for different organ dysfunctions, and sepsis can look different on the wards as a result. So what can hospitalists do? What is the role of hospitalists? I divide this up into micro roles, the individual doctor-patient roles, and then more macro roles. This is changes at the ward level, the hospital level, or the health system level. From a micro standpoint, really the key first step is recognition, partnering with your nurses, thinking sepsis, being willing to engage your more active cognitive processes to try to put the pieces together, and then really driving the bundle implementation. Knowing your team, you need to facilitate timing and instill a sense of urgency. If you have a brand new floor nurse out of nursing school, they may not understand or know how important it is to get the antibiotics in within half an hour, within an hour, as opposed to passing the 9 a.m. meds. And really at the bottom line is just doing what it takes. If you need to draw blood. Be aggressive with fluids and be aggressive with monitoring. We under-resuscitate on the wards. I think the intensivists have suspected this for a long time, and I can confirm I and my colleagues aren't nearly as aggressive as we should be. And we have good reasons for that. We have well-meaning logic behind that, but I think that there are counters for all of that, and the bottom line is our patients need it. Communication, and then timing of transfer. I'm not going to spend time talking about where these patients should receive care. The way that I've always approached this is matching patient care needs to the resources available. If that's through rapid response teams, if that's the ICU, if that's a step-down unit, you need to know your hospital, and that will help you determine where these patients receive care. And then involving your ICU early. The handoff to the ICU needs to be key. Needs to include detailed information of what you've done and what you have left to do. From a macro standpoint, hospitalists need to be active in quality initiatives. Hospitalists are attending physicians who have frontline experience. They're writing orders. They're really the ones who see how things work and don't work. And so they need to be involved in unit-based, hospital-based educational initiatives and quality initiatives, whether that's grand rounds, whether that's presenting to their group, or working with students and residents. And then partnering with your intensivists, your ED physicians, and your nursing staff on handoffs and bundles and protocols. And then using data to drive improvement is of course integral at every point. So in summary, recognize. A lot of these patients are going to be on the wards. Deliver the care that is indicated, and really be active in driving improvement efforts, particularly in partnership with nurses and nursing leadership. Thank you.
Thank you very much, Andy. So all these strategies and options and ways to take care of patients on the wards, now we have the opportunity to see what happened in our collaboratives and get some results. I can introduce Dr. Mitchell Levy, who's Division Chief of Pulmonary Critical Care and Sleep Medicine at Rhode Island Hospital, Professor of Medicine at Brown University, past President of FCCM, a founder of the Surviving Sepsis Campaign, and he happens to be the only member of the Surviving Sepsis Campaign who's independently wealthy and has his own corporate jet.
Great. Thanks, Sean. I don't have any disclosures. So I want to take the next 20 minutes and talk to you about some of the data about why we've done this initiative altogether and the results of the collaborative that you've heard described by our speakers in a really good way. So we've been talking about doing something on the wards for a long time. For the first 7 to 8 years of the Surviving Sepsis Campaign, we really concentrated our efforts, as you've heard, in the emergency department and in the intensive care unit. And part of that is because the campaign is comprised of ICU docs and nurses, and when we get to the wards, we get very disoriented. It's not chaotic enough, it's not loud enough, and so we get really confused, and so we run back to the emergency department or the intensive care unit. But throughout the 8 years of the campaign, we have said that that is a very vulnerable population. And Andy did a great job of explaining the anatomy and the barriers that turn the population of patients on the hospital floors into a very vulnerable population. And what I want to show you first in this talk are a little bit of the data that have come from the campaign that identify where these folks are and how sick they are. So this is something that we published in Lancet ID that shows that in the campaign, this is the campaign database, about 28,000 patients, and you see that in the U.S., 25% of the patients in the database with severe sepsis were on the wards, and in Europe, that's reversed. About 50% of the patients in the database are actually are on the wards. What happens, this is a small pilot study that predated a lot of what we did at Brown at Rhode Island Hospital, and we just did a retrospective study at looking at patients who wound up getting transferred from the wards into our intensive care unit. And we found that they spent an average of about 50 hours with signs and symptoms of sepsis and severe sepsis prior to MICU transfer. Patients with shock obviously were transferred faster. Abnormal white count and tachycardia were present longer than any other signs and symptoms on the patients on the wards. And bandemia, greater than 10%, actually was statistically significantly associated with mortality in this population. And the average time difference in transfer between survivors and non-survivors was about a day. So there are a lot of data. This is only one piece in the literature that shows that people who develop severe sepsis and septic shock on the wards do worse. This is from our antibiotics study that we published in Critical Care Medicine. And you see here, I think you all know that from the Anand Kumar data, and we repeated this in patients not just with septic shock, but also with severe sepsis, about a 7 to 10% increase in the odds ratio of mortality for every hour delay in receiving antibiotics. What we also showed was this was present not only in the emergency department, but on the wards as well. And more importantly, and I think this is a very interesting piece from that manuscript, if you look in the ED, you can see that the percentage of patients with each hour delay goes down over time in the emergency department. That is, that the number of patients who have delays of 2 hours, 3 hours, 4 hours is less and less with each hour. But when you look at the patients on the wards, the patients and the percentage of patients with a 1 hour, 2 hour, 3 hour, 4 hour delay actually goes up on the wards. So in fact, the percentage of patients with delayed antibiotic administration increases over time on the wards as opposed to the emergency department, which certainly in part explains the higher mortality we see in these folks. You see here, we published this in Lancet, also the mortality rate in the U.S., about 35% patients on the wards, which was almost identical to the patients with nosocomial infections and severe sepsis and septic shock in the intensive care unit, and the same was equally true in Europe. And we also were able to show that patients on the wards have about a 20% increase, severity adjusted, in the risk of dying compared to those patients who come in through the emergency room. And that's what led to this more funded collaborative that you heard about over our previous 4 or 5 speakers, 18-month project. As Sean alluded to, there were 4 collaboratives. You saw Steve present some of the data from the Adventist collaborative, and the 3 other collaboratives were geographically located. And you see some of what was involved: 4 face-to-face learning session, monthly calls that were separated into each of the regional collaboratives. And I want to emphasize one thing, because I think before I even show you the data, I actually think you've already seen what I think, in many ways, is the most important outcome from this collaborative. And that is, we were able to demonstrate in each of the collaboratives regionally the feasibility of screening every patient, every shift, every day. And in an environment that's under-resourced, and Andy did a great job of describing the anatomy of the wards, to be able to demonstrate that the nursing staff on the wards, who are overworked and under-resourced, were able to incorporate into their workflow across 4 collaboratives, across 38 hospitals, routine screening is a remarkable achievement by these nursing staff of these 38 hospitals, and a very, very important statement moving forward when we start to approach initiatives to treat this vulnerable population.
So thank you all. That concludes our presentation part of the meeting. We'd like to turn to questions from the audience at this time. Thank you for holding your questions throughout most of our presentations so that we could have some time at the end to have a reasonable and informed discussion. Before we turn to that, though, I would like to reintroduce Mitchell and Christa, who have some thank yous that they'd like to give regarding this project.
Yeah,
we thought we would do this in person rather than just impersonally on a slide. And there's a lot of people to thank for this 18-month initiative. I'd like to start with our nurse faculty, Marianne Barnes-Daly, Trish Turnell, Pat Posa, Patty McCormick, and of course, Christa Shore.
And our physician colleagues, the hospitalists that were involved in this program, Andy Odden, Kayla Pale, Lisa Shea, and Arup Pale. Our intensivists, Mitchell Levy, Sean Townsend, Phil Dellinger, Steve Simpson, and Laura Evans.
And also our performance improvement experts who worked with us from the beginning, Jane Taylor and Diane Jacobson. I really especially want to thank the folks from Adventist who were supportive all along, Lauren Hauk, Steve Knych, obviously, Laura Hebert, and just the Adventist group of nurses and physicians in general. And then finally, most importantly, this would not have been possible without the help of Lori Harmon and the FCCM staff. Lori has been such a strong supporter of the Surviving Sepsis Campaign over the years, and we owe her an enormous debt of thanks and gratitude for the work she did with us in the campaign, so thank you. And of course, Deb McBride, who remains a mainstay of the campaign, who's been with us really from the very beginning, and pretty much every word you read of the Surviving Sepsis Campaign makes sense because of Deb. If you think it makes sense.
So with that, I guess we'll start at number 1 and go to number 2.
Hi, Craig Weiner, University of Minnesota. A lot of talk about teamwork. That's great. Teams work together. But there is a difference. Nurses are licensed as nurses and physicians are licensed as physicians. And we had a lot of pushback when we implemented these kinds of sepsis protocol at the University of Minnesota regarding who's writing an order. Actually, for the first time, we allowed nurses to draw lactates, order a lab test on their own based on the vital sign alert going off. We also found physicians who didn't think that their patients needed lactate drawn, writing specific orders in the chart saying, ignore the sepsis protocol excessive, do not draw lactates. And it became a fight as to which order became relevant. And then the second thing is in the ED, when the sepsis alert goes off, the triage nurse has the capability to say, I'm suppressing this alert because this is probably not due to sepsis. On the wards, when we tried to introduce that, the nurses felt very uncomfortable about making a judgment as to whether these abnormal vital signs are due to the presence of an infection or not. They thought they were essentially being asked to practice medicine, and we told them they agreed that they did not want to take that responsibility. So comments from the panel regarding the roles of the various providers here.
Yeah, I'll start off the hospitalist perspective. So I will say I actually learned to manage sepsis at the University of Minnesota. That's where I did medical school in my intern year. I can say your hospital is not unique. I can say that from direct experience that physicians and nurses both do not like having change forced upon them. I don't have a magic bullet for the problem, particularly of the lactate orders and protocolized treatment. I am a believer. A lot of my partners over the years have not been. I think one of the keys is to have a physician champion and a nurse champion that can help to develop solutions that will fit for your particular group, your particular hospital, because that is going to be different from institution to institution. State licensing and nursing board regulations vary, practices vary, but I do think starting with a physician champion and a nurse champion is really the only way to go about it, because anything that gets imposed upon a group of physicians, there's going to be active resistance to.
From the nursing standpoint, we had a similar effect, that the nurses were reluctant to participate initially with the screening because they felt that they were actually diagnosing the patient and they didn't feel comfortable with it. We actually changed that particular mechanism where initially we had the screening tool had different sources of infection, endocarditis, pneumonia. Then we just changed it to an active or suspicion of infection as opposed to what we consider a diagnosis, and they felt much more comfortable with that. if we've noticed, we actually gave the nurses an opt-out so that they could actually reassess the patient before making a decision. And we noticed that there were nurses that were hitting that button for their whole shift because they were so afraid to make a diagnosis. And we actually collaborated with the nurse educator in that particular unit and did some one-on-one education, and that seemed to be very helpful. There were some nurses that felt very confident, but these floors are generally the nurses that are new out of nursing school. They're just learning how to be a nurse. So incorporating this into their workflow was somewhat of a challenge. As far as the physicians, we felt in our institution that we actually did the same thing that we did as far as nursing education. We showed them the data. I find that physicians in our facility are very responsive to data. That's what they want to see. They want to see how are they performing differently than someone else. And we showed them a case. We pulled all the hospitalists on that particular unit and showed a case that they all had involvement in because the patient was in the hospital for a long time, and showed all the areas where they potentially could have improved care for this particular patient who eventually died during that hospitalization. So that's a helpful driver. And as Andy said, we had a key champion. So if the nurses had any conflicts where the physician wasn't responsive, they were able to call the hospitalist champion, and he would have a sidebar discussion with that particular clinician, because we felt that physician-to-physician communication in those particular instances worked a little bit better.
I would just remark that I think what you're describing is most clearly known as growing pains. It's the establishment of screening and protocols, getting acceptance, and having people believe in it. And I would encourage you not to stop the work you're doing. It's a key place where administration is necessary to be involved in the work. Administration contracts with the groups, the medical groups that provide the care, and this is where administrators can lean on doctors and those who are resistors to become more compliant, or at least to take their resistance and keep it to themselves, which is oftentimes important as initiatives get established. So just don't stop.
Hi, I'm Michael Rothman from ParaHealth. It's a very impressive reduction in mortality, but when I see results like that, I worry about sort of the denominator effect. And I'm wondering, have you looked at the overall risk-adjusted hospital mortality to see how that's changed over the 18-month period?
Yeah, so no, we haven't. I mean, there's no question that to a certain extent we diluted out the denominator. One of the ways, and I alluded to it when I was speaking, the very success of the study is what raises into question the results to a certain extent. So the goal of the collaborative was to identify patients with severe sepsis earlier. And by definition, then, our success in doing that means the patients were less sick. So what we tried to do was a severity adjustment to show that even with severity adjustment, the mortality rate went down over time. Is it possible that the overall hospital mortality went down? It is, sure. And to a certain extent, that will always be the criticism of any performance improvement or quality improvement work.
We are beginning to, with our spread plan, we are beginning to look at that, because the collaborative, as Mitchell said, was just on one unit in the hospital. But now with understanding where our baselines are and taking the same approach to measuring that, we're hopefully going to be able to understand how this is impacted once we do get house-wide spread.
If you think about these data for a moment, and your criticism is well taken, and you hear we confess essentially to the fact that those are some troubles with interpreting the information, the directionality and intuitive nature of the work and the results that we find, I think does lend support to the work we've done and encourages hospitals to move forward, and should. It's much like what Dr. Beal was talking about earlier with the MERIT study and rapid response teams. Although they'll never exactly be beyond a reasonable doubt proof that screening for sepsis reduces mortality and saves lives, there's certainly a preponderance of evidence that reflects that, to use as an analogy again. And to a large extent, I think hospitals will have voted with their feet. Certainly CMS has, and asked us to identify these patients with the SEP1 core measure, which many of your hospitals are now focusing on. And so will we ever have conclusive proof? Maybe not, but it's clearly the movement and the way we're moving. direction we're moving.
Thank you.
First of all, I want to thank the panel for an amazing presentation and recognizing that patients on the wards are probably a bigger problem. I think what comes to the ICU and the outcomes are, from the ward can really change our ICU outcomes, so this is really very important. I have a controversial question about monitoring or sepsis screens for patients in the ICU versus on the ward. Since the level of awareness is significant in the ICU and resources are limited, people who have electronic screens, should they actually suppress the screens in the ICU and keep them specifically on the ward? That's number one. Number two, does the panel feel that there is a need for a separate sepsis team rather than an MRT team? And finally, what do you think about variability in physiological parameters for different age groups? An 18-year-old is not the same as a 90-year-old patient. So should there be different variabilities in what we actually call sepsis?
I think what your question calls for is, don't we really need a smart person to watch everybody in some ways? Alarm fatigue is a big deal. The national patient safety goal that the Joint Commission has announced for United States hospitals in 2015 and 16 includes a reduction in unnecessary alarms around the hospital. And we've all seen what happens when you get best practice alerts and so forth that you want to click off because, yes, you know the patient has a central line. In fact, you put it in yesterday, and yes, you do want to keep it. These become parts of the background noise to the work we do in the ICU. It's balance. It's finding the right element of alerts versus not the right amount of alerts, continuous sensitivity to the process to make sure you don't make physicians likely to click them off. Of course, you have to be sensitive to disruptions in physiology, but mostly we're talking about the adult population where the same perturbations, I think, by age are all alarming. Certainly children or obstetric patients may be different, so there is room for judgment, and I don't think you can ever escape the person that has to be in the middle of it.
Yeah, at Adventist, when we started this journey 5-6 years ago or so, we have, as I said, a Cerner shop, so we have the St. John Sepsis Alert in place. We, after the first maybe month, turned it off in our ICUs simply because there was too much noise. It wasn't providing additional value to what was being seen. We also saw that in some of our procedural areas like PACU and on our labor deck. We also built in a suppression rule that helps to manage the alerts and, as Sean mentioned, deal with alert fatigue and so forth. So we've taken those steps along the way.
So we have about 1 minute and 45 seconds left for questions, and so I'd like to get you all if I can. So we'll try to take one speaker and make an answer if that's possible. Number one.
Hi, Sandy Tobar from Trinity Health, and my question is: in using the sepsis screening and assessment tool, would you recommend using that in the obstetric population?
I'll take this question. So the answer is yes. There actually is, and I've done a lot of work looking at this, there is not a great literature in the obstetrics literature that actually suggests that women who have just delivered babies actually have substantially different physiology than other adults. There are concerns about elevated temperature, elevated heart rate, perhaps due to hypovolemia associated with the delivery. These types of questions come up. And it seems that the more we repeat that there are differences, the more we begin to believe that there are differences that are meaningful. The flip side of that is that the obstetric patients who are identified late or who we don't use sensitive criteria on and develop sepsis, develop such profound sepsis that it is truly a nightmare for providers that render care for these patients. Many of us on this panel have been consulted in cases where obstetrics patients have become severely septic or developed shock, loss of limbs, in a newborn, or rather in a mother who's got to care for a newborn is not an acceptable consequence. So the CMS core measure has no plans to alter, for example, the screening criteria for obstetrics as a population. And I would ask you to, for those who call for that, ask them to produce documents and papers that prove that there's a need for that in the severe sepsis population in obstetrics, because those papers don't exist yet.
Hi. Thank you. Thank you to the panel and everybody in the collaborative. It really was a positive learning experience over time. Question related to what many people are thinking about now is the definitions, fitting it into where we're at and how to move forward and not lose the positives we've gained. Christa point to this. In our collaborative, there was a lot of problems with definitions, and the word simple sepsis came up a lot. And I heard Dr. here talk about the term early sepsis, and I wonder if that would be a term that would work, because one of the concerns I have is that we may get to a point where people are now saying, well, Q-SOFA is the only thing that's going to trigger me to do something, and I don't think that's going to be good enough, because we really need to stick with what we were doing to identify and do the blood draws that we've now gotten, med executive boards to allow nursing to then get this done on a quick fashion. And I don't want to go backwards in time. I wonder your comments on that.
Yeah. So I don't think early sepsis is severe. We have enough problems with terminology to add anything more.
I get that. I'm just trying to figure my way around.
Yeah, I'm of the mind that I share your concern that people are going to misinterpret Q-SOFA to mean we don't act. But remember, all of the data that we did with Q-SOFA was in an infected population. And so it's very colored by that. Right. So we still have to screen for patients with infection. And we are still going to wind up using the signs and symptoms of inflammation and infection to diagnose infection. And so it's still the case that when you see someone and they have a fever or bandemia and you think you have a source, you're going to initiate antibiotics. And you're going to start to get lab tests to identify whether they have a dysregulated organ dysfunction. You're going to look at their creatinine, you're going to look at a lactate, you're going to look at their coags. And once that signal goes on, you now have a patient who would formerly be called septic, severe sepsis, and is now called septic, and you're going to initiate the 3-hour bundle. So I think it's going to be a learning process for people to understand that Q-SOFA has nothing to do with initiating treatment. And more importantly, as Mervyn presented it yesterday, Q-SOFA is, to a certain extent, hypothesis generating. We're really looking forward to prospective trials that compare how to screen, et cetera, et cetera. So we're not putting Q-SOFA forward as now the new screening criteria that should only be used and be met before initiating the 3-hour bundle or therapy.
Excellent. Thank you. Great.
That's one more question over here on the left.
Please, Arthur St. Andre, Washington, D.C. Forgive me if you answered this earlier. Relative to the scores, if they're serving for us as a red flag to indicate patients at risk for increased mortality and morbidity, to what degree should we care that they're specific for infection if they help to bring resources to evaluate patients earlier?
Absolutely agree. I agree with you, Art, and it's a good question. But and so that's very true. I think Q-SOFA, will stand the test of identifying patients who are likely to deteriorate. However, they are not meant to be waiting until they meet those criteria to treat. Two very separate processes. And I think as the field becomes more comfortable with those two processes, they'll be able to be utilized better, appropriately.
Well, we are running short on time. If there are no further questions, we thank you for joining us today and appreciate all your attention to this topic. And we're glad you stayed to the end. Thank you.